So we are going to start the next session on RAS pathway. We have two great speakers, and here with my colleague, Dr. Pilar Garrido. My name is Dr. Edgardo Santos from the Oncology Institute of Hope and Innovation in Florida, the United States. This is perhaps not because it's a session that Pilar and we are conducting, but perhaps the more challenging one, because as you know, RAS pathway has been considered an undruggable pathway until 2021. So it took all of us more than 40 years, I repeat, 40 years in the discovery of RAS to get the first inhibitor in this pathway. So Pilar, you can introduce the speakers. Thank you.
Sure. So we have two speakers and then a panel discussion. The first speaker is Dr. Natasha Leigh from Princess Margaret Cancer Center in Toronto. She's going to talk about KRAS G12C, how should we move from monotherapy. Thank you, Natasha.
Thrilled to be here, thrilled to have my mic on. I did actually just give a talk not long ago with no slides and no mic, so you know this is really nice. I also really want to thank Delvis, Charo, and Luis. It is also sunny in Toronto where I'm from, but it's not quite as warm as it is here, so really thrilled to be here. Thank you so much. So I thought I'd start with a case. This is actually my patient who's been on KRAS inhibitors the longest, ex-smoker, had bone metastases and lung lesions. Really not much of a sample. This still happens in Canada. I don't know if it happens here in Gran Canarias. So she was treated with chemo-IO. PD-L1 was 1%. And then progressed. And she was sent to me for a liquid biopsy study because that's still not freely available in Canada, and she was found to have a G12C mutation. And so you know very well that this is really the most highly mutated gene across cancers, certainly solid tumors, and in particular G12C is most common or has the highest frequency in lung cancer as opposed to pancreas cancer where it's almost all G12D, and colon cancer where they have some patients with G12C mutant colon cancer but not as many, and then of course different in skin and other tumor types. More common in smokers. We see it in adenocarcinoma. These tend to be inflamed tumors, and much more common in Western populations than Eastern populations, even with differences in smoking. So, less than 5% in Asia, as opposed to, 15% or so in Europe and North America and Latin America. And you're all very familiar now, and you get to use these great KRAS off inhibitors that really covalently bind to KRAS in its inactive state, or its GDP-bound state, as you can see at the top right there, where it's inactive. And it's actually kind of amazing that that works, right? If this is cycling and it's going back and forth, we know that in KRAS wild type, there's supposed to be a balance of cycling to on and off. But once you have a mutation in the mutant protein, you're really shifted towards on signaling or GTP-bound KRAS. So it is kind of amazing that by binding the off moiety of KRAS, that you can actually decrease that signaling and really take some of this out of the circulation. The risk, of course, some way to find reactivation of KRAS-bound, GTP-bound KRAS. So Dr. Solange Peters and Dr. Ayana asked me some years ago to give a talk on KRAS, and back in 2021 when I gave this talk, I said, here we are, chemo-IO for patients with advanced lung cancer, then a G12C inhibitor, and imagine where we're going to go. And at the time, I thought that by 2022, we would already be there because things were moving so quickly in lung cancer. We would have frontline KRAS inhibitors. We would have combinations. We would be using this in patients with STK11 co-mutations. And yet, we still seem to be in 2021. So one of the ESMO guidelines recommend testing, of course, including for KRAS, standard treatment for first line, whether it's immunotherapy or chemoimmuno, and then second line monotherapy, both with sotorasib and adagrasib, both conditionally approved in Europe and with accelerated approval in the US. And, it's been interesting with response rates of 40% and median durations of response of almost a year. I think we all thought that this was going to be a shoe-in for second line and very likely to move to first line. But docetaxel, my former mentor, Frances Shepard, who is quite tough and is responsible for the approval of docetaxel in lung cancer, her drug is also proven similarly tough and was very hard to beat. Some improvements in progression-free survival with sotorasib and adagrasib, but a bit worried that neither of these is a home run. In terms of safety, I think many of you already know diarrhea, something to watch for, transaminitis as well, especially if you're within that 3 months of a checkpoint inhibitor and there's still occupation of the PD-1 receptor by your immune therapy or your checkpoint inhibitor. But by and large, pretty manageable. One of the questions always, do we have the right dose? For example, with sotorasib, depending on who you are, you think the right dose is 240 milligrams or 960 milligrams, and most of us think it's probably somewhere in between. So, we're learning that dosing in these drugs is very, very important. Both have intracranial activity. I think qualitatively, most people think from the data that we've seen that adagrasib probably has greater intracranial activity, although of course there are no comparative studies and the data that we have seen are somewhat similar from randomized trials. And so you would think between 2021 and 2025, we would really have moved toward the first-line setting, but instead we've been spending our time looking at many exciting new KRAS G12C inhibitors, including new ON inhibitors, in addition to OFF inhibitors. And my colleague, Adrian Satcher, who does most of our RAS trials in Toronto, has described this as the Wild West of oncology drug development. Every time you look around, it's like whack-a-mole. There's a new G12C inhibitor that pops up. So, I didn't put this on here to suggest that all KRAS inhibitors are the same, but you can see that the activity is generally comparable across these OFF inhibitors, anywhere from 45 to 55%, median duration of response, anywhere from about 6 to 8 months, up to about 18 months. And so, how are we going to be able to move forward and pick one drug over another? Perhaps CNS activity, as we've seen with adagrasib, perhaps toxicity, and I think there are a couple of drugs to call out. I think divarasib, garsirasib, fulsarasib, and opnurasib, the Novartis compound, these are all drugs where there is a much lower rate of severe toxicity. But again, is it that the drug is so much better, or is it that the investigators did a much better job of figuring out the optimal biologic dose? So this is also something that we need to think about this. But at the end of the day, as single agents, these drugs probably aren't going to move to the first line. So our ability to combine these safely with other current standards or novel agents is really going to be the thing that differentiates these. So there are a number of Me Too trials that are still waiting to read out, opnurasib, also divarasib compared to docetaxel. I think we hope that the data will look better. I'm a little worried they may look very much the same. And a beauty contest. I was going to put a picture of Luis and Eddie on here, and I thought maybe it wasn't fair. But this particular beauty contest, divarasib versus adagrasib, both of you are beautiful in my opinion, has fully accrued, and we'll wait to hear the results. I suspect divarasib may be at a better dose. We'll see if it has better activity and better toxicity compared to our current standards. We also learned early on that some of our patients who maybe don't respond to checkpoint inhibitors might respond to KRAS G12C inhibitors. So Dr. Yenna presented some data on adagrasib, Nando Skalidis presented some data on sotorasib, that patients with STK11 co-mutations in particular with KRAS G12C were much more likely to benefit from single-agent G12C inhibitors than other drugs. And so to really test that, there are a number of studies now that have, I think for the most part, fully accrued, looking at patients with STK11 co-mutations. One's the lung MAP study looking at sotorasib, one's with glesirasib, and one is with opnurasib, looking at patients with PD-L1 positive and STK11 co-mutant lung cancer to see if maybe this really is a group where we might preferentially want to move forward rather than with immunotherapy or chemo-IO, maybe with a single agent G12C inhibitor. But what's interesting, we've seen this with STK11 co-alterations with KRAS G12C, but by and large, most of the studies looking at co-alterations suggest that these patients do worse really with everything. immunotherapy, chemoimmunotherapy, and probably even G12C inhibitors. So KEAP1, SMARCA4, CDKN2A mutations, these are all associated with worse outcome when identified in our patients with KRAS mutant lung cancer. And in a recent Chinese study, they also found that STK11 potentially had a worse outcome with their G12C inhibitor, fulcerasib. So again, this concept, just like with EGFR, ALK, and all the other cancers that we treat, more co-alterations means for worse outcome. And can we do better than monotherapy? We've learned in the lab that G12C inhibition really heats up KRAS mutant lung cancer. You see more antigen presentation, more T-cell infiltration, more interferon signaling, and you see a downregulation of that immunosuppressive environment in tumors. These are some nice data presented by Dr. Yenna at ESMO IO a few years ago, where with adagrasib you can see these tumors light up, and you can see TILs and more inflammation, and very similar data from the sotorasib program. You can see that with exposure to the G12C inhibitor, you can see more inflammation, and if you combine this with checkpoint inhibition, you can see a near 100% survival of your xenograft models. So is this the perfect cocktail? Can we put this together? Is this a perfect drink that we'll hopefully have this evening once we're done this marathon day of lectures? And so there have been a lot of studies now, and there's been a lot of activity here, and by and large, the response rates are very promising. Those of you who have patients on these trials, I think we all think that this is the way. I mean, this is incredibly promising. Patients tolerate this well. So many of our patients have now been on these trials for 1, 2, 3+ years. Response rates anywhere from 50 to 77%, depending on the population and the agent used. And perhaps this signal, like in many other tumor types, that if we move to the first line, our patients might do better. And what about chemotherapy? If we can add a checkpoint inhibitor, surely we can add chemo. And you can see here that the response rates when we add chemotherapy to G12C inhibitors are very exciting, 75%, 67% in PD-L1 high patients and patients with PD-L1 high tumors, and 60% in patients with PD-L1 low tumors, which probably is higher or at least as good as chemo IO in that population. A recent study from Japan that's just been published shows a response rate of 90%. I think the duration of response maybe is a little concerning, probably in the range of six months or so perhaps not that same immunotherapy effect with prolonged benefit that we see, but certainly see it across PD-L1 expression subtypes. The other problem is, though, unlike maybe EGFR mutant lung cancer, as we learned this morning, when we see these co-alterations, just adding chemotherapy maybe isn't the answer. In the Japanese study, when they looked at patients that received sotorasib and chemotherapy, those patients on the right who had the best outcome were those who really had sort of single alterations, just G12C and no co-alterations. So I think our ability to overcome co-alterations, that certainly remains a bit of a challenge. So what happened to my patient? So she started on a sotorasib study. She did very well despite being at full dose, and she had, in the end, a complete response and was on treatment for 27 months. Which I think distressed our coordinator greatly as this very challenging patient. So what happened after 27 months to this particular patient? And this is a slide from Dr. Chiara Ambrogio. There really are different types of resistance, just as you've heard about all day. Intrinsic resistance, likely those patients with co-alterations, patients where these drugs were never going to work. Acquired resistance, so whether it's a de novo alteration, this on-target, off-target, state transformation or lineage plasticity that we see, very similar to the EGFR story. And then also adaptive resistance, right? So these drugs bind KRAS in its off position or inactive position. Surely it's not that hard for cells to figure out how to turn this back on. And so some of the different adaptive mechanisms, I think, are of great interest. And we've learned that this is complex, just like in EGFR. Perhaps this is even more complex, but again, that same idea, on target, and how do we target that? Off target, perhaps we add new alterations, mostly in colon cancers where we see emergent fusions, and then of course, things like small cell transformation. So one of the possibilities, of course, is instead of targeting KRAS G12C in its off formation, is to target it using an on inhibitor or in its activated state, where, of course, this is the ideal because there won't be any reactivation of that KRAS pathway. And there are some drugs that are now in clinical trials. This was presented by Dr. Yenna, I think over a year ago now. And you can see that in patients that received this new KRAS on inhibitor from Revolution Medicine, you can see a 50% response rate, which is very impressive, but also all those patients toward the end with hashtags, those are all patients who failed a G12C off inhibitor. So this does actually overcome resistance to our current therapies. And so should we start with the on inhibitor, kind of like lorlatinib and alectinib as we heard earlier? Should we combine and do them both? Not sure what the diarrhea will be like with that, but certainly an important question. Or do we sequence? You know, I think a lot of us still want to sequence these drugs to really prolong patients' chemo-free time, and I think these are all studies that we need to do. We're also learning more about non-genetic resistance, so this other form of adapted resistance, and there were a number of papers published across different tumor types, pancreas cancer, colon cancer, lung cancer, among others, and what they found was some of what Dr. Yenna talked about this morning. YAP, TAZ signaling, TEAD as a target, really important to double down on apoptosis as we try and overcome this resistance or adaptive resistance to targeted therapies. This is also true in KRAS. And so maybe some of the things that we've read about for ALK1 resistance and EGFR resistance, these may also be very true for all of our oncogene-driven cancers. And so, you know, there are a number of drugs that can target TEAD that are being developed in the lab. They do seem to prevent resistance to G12C off inhibitors when they're added into the mix. And so, of course, the next step is, do we add this to patients in the clinic? Do we start with a combination up front to decrease the likelihood of resistance, or do we add it when the time is right? And how do we know when the time is right? You know, do your ctDNA levels rise? Is there going to be some kind of magic marker or, you know, interval PET scans where we know that your drugs aren't working? So I wasn't sure which was worse, my making a table of all of the different studies of combinations that are ongoing, or showing this, which is this is a wonderful cartoon of all of the different ways that we could overcome resistance to G12C off inhibitors. So obviously on inhibitors like we talked about, some protein degrader strategies, also upstream. So for example, in colon cancer, you'll know that recently cetuximab and sotorasib has just been approved for the treatment of colon cancer. Not as effective yet in lung cancer, but maybe we just haven't picked the right patients. SHP2 inhibitors, SOS1 inhibitors, as well as a number of downstream pathways that can be blocked. Also, pan-RAS inhibitors, again, on inhibitors that maybe really eliminate that ability for the cell to start moving around and evade our targeted therapy. And we'll hear more from Dr. Odias about that. So what did I do with my lady? I think what most of us do. You know, I tried to repeat a biopsy. I probably didn't do the right kind of testing. We didn't have access to whole genome. We found an STK11 mutation. We were able to get her on a SHP2 inhibitor study, and apparently these are very difficult combinations, and apparently they don't work. But my lady's had another complete response, and she's been on for 3 years. So again, you know, who needs what? When do they need it? How do we know? I think these are all really important and unanswered questions. So moving forward, you know, I suspect that these drugs will come in the way we currently treat lung cancer, PD-L1 high, a G12C inhibitor, plus an anti-PD-1, low, probably adding in some chemotherapy at a certain threshold. With co-mutations, I think we'll see if monotherapy is a good approach or was just a little too brave. And also, how do we look at adaptive resistance? How do we look at emergent resistance? You know, will liquid biopsy be what we need? Will it be as clear as the EGFR story that we heard about earlier? So with that, I want to thank you so much. It's really been a thrill. I hope that you'll all come and visit me in Toronto sometime. Please don't come now. It really is freezing. But I do hope to see you sometime, hopefully in our summer. Thanks so much.